Hey guys, hello everyone. So let's continue our discussion on pathophysiology. Let's look at this one. So question number 83. So we are going to talk about the pathophysiology of blood, right? So before that we have already discussed that in class. So if you look at question number 83, right, what we can see over here is that they are talking about the Minkowski-Shoffer disease, right? What they are talking about over here, they are talking about the Minkowski-Shoffer disease, and we know already that about Minkowski-Shoffer disease. In the Minkowski-Shoffer disease, first of all you should know what is the problem. The problem is that in this one we are having membranopathy, right? Membranopathy. Because why there is membranopathy over here? Membranopathy is there because we know that as we have already discussed in the class, okay, in the membranopathy what is happening, there is a problem with the ankyrin and spectrin protein. Okay, so what is the problem? Ankyrin and spectrin protein, right? They are not actually working over there, right? Or you can say the deformation of these proteins may lead to membranopathy, and we are having the problem of Minkowski-Shoffer disease, right? So what can be the answer over here? Now look, if the ankyrin and spectrin proteins, what is the main role of these proteins over there onto the membrane of RBC? They are actually maintaining the integrity of the RBC, right? They are maintaining the shape and size of the RBC. So if they are not uh, if they are actually deformed, then what may happen further? Yes, there can be the deformation of the shape of the RBC, and they can take the shape of the sphere, and we are actually calling that as spherocytosis, right? So what can be the case over here? What can be the answer you can say over here? That can be actually microspherocytosis, right? That can be actually microspherocytosis. Okay, so that is the case as far as 83 is concerned. Okay, so now if we talk about question number 84, in the question number 84 they are talking about the anti-hemophilic globulin A, right? Anti-hemophilic globulin A, factor number 8, was found absent in the blood plasma of a 3-year-old boy with pronounced hemorrhagic syndrome. What phase of hemostasis is primarily broken in such? Factor number 8 deficiency, right? So factor number 8 deficiency, what can I say about that? Factor number 8 deficiency is actually leading to hemophilia A. Okay, and I know this thing as well, that factor number 9 deficiency, right? What I'm saying, factor number 9 deficiency. Okay, 9 deficiency can, we are talking about deficiency factor number 9 as, that is actually hemophilia B. Hemophilia B, and hemophilia B we are calling that as Christmas disease as well. Okay, Christmas disease, right? So that is the case over here. And what they are saying that due to that, if there was factor number 8 deficiency, factor number 8 was found absent in the blood of a 3-year-old, so he must be suffering from hemophilia A, because there is a antibody against it, right? Anti-hemophilic globulin A. So 3-year-old boy with pronounced hemorrhagic syndrome, right? So what they are saying, they are talking about the hemorrhagic syndrome further, right? What phase of hemostasis is broken? So look, if you talk about the factor number 8, right? Factor number 8, what I know about that factor number 8 is, so look over here please. So if you know about coagulation cascade, we are having two pathways, right? So about the coagulation cascade, we are having two pathways, one is extrinsic and one is intrinsic. So one is intrinsic and another pathway is extrinsic, right? Now if you talk about intrinsic, so look, 12 converts into 12a, further 12a actually converts 11 into 11a. 11a converts your 9 into 9a, right? And now look, 9 is converting your 10 into 10a, right? 9 is converting your 10 into 10a. And further, meanwhile 10a was converting your factor number second into second a, right? And second, we know factor number second is also called as, yes, that is prothrombin, and factor number 2a, that is also called as thrombin. And further, we know what is actually happening. Second a is actually helping to convert factor number 1 into 1a, right? And factor number 1, we are also calling that as fibrinogen, which is an inactive form, right? Which is actually finally converting into fibrin, which is a very important part of the coagulation cascade, right? So that thing is happening over here. Meanwhile, what you should remember over here is that this step is very crucial. Which step I'm talking about? This step is very crucial, because look, it is actually taking the help of many coagulation cascade, many clotting factors, you can say, because 10a is not alone involved over here. Okay, along with the 10a, we are having the conversion of, meanwhile we are having the conversion of factor number 8 into 8a, right? Now if you look about this one, 8a, 8a is actually responsible for the production of a very important complex that is also called as prothrombinase complex, right? That is also called as prothrombinase complex. So this prothrombinase complex will actually help to convert this second into second a. Okay, so I can say that this factor number 8 is actually helping you to form prothrombinase complex. Okay, prothrombinase complex, and this further prothrombinase complex is helping in this conversion, right? So if you look about our question, okay, so once again, this was the coagulation cascade pathway where the conversion of second into second is happening with the help of 10a and the prothrombinase complex. Let me tell you one more thing, that this prothrombinase complex is actually carrying what? Prothrombinase complex is actually having factor number 10a, okay, factor number 10a, along with that factor number second, and along with that factor number 5a, okay, factor number 5a. Okay, that is a prothrombinase complex. Now if you look at our question, they were saying that hemophilia A was a problem, hemorrhagic syndrome is there, which means that there is some kind of problem in the coagulation cascade. If they are talking about factor number 8, they are talking about which one? Prothrombinase activation problem, right? So I can say over here is that there is a problem of intrinsic mechanism of prothrombinase activation. Okay, intrinsic mechanism of prothrombinase activation, right? So that is a problem over here. Okay, now moving further, now let's talk about the next question. As you can see over here, they are talking about the cyanosis, they are also talking about the dyspnea, which is also called a shortness of breath, and they are talking about the convulsions, formation of hemoglobin of what form? Hemoglobin of what form, right? So in the cases of cyanosis, and let me tell you that they are talking about which poisoning. They are talking about the nitrate poisoning over here. Okay, and we already know nitrate poisoning will actually lead to the formation of which kind of hemoglobin? That is the methemoglobin, right? So what can be the answer over here? That is the methemoglobin. Okay, so what can be the answer? Which is the form of hemoglobin? That will be the methemoglobin. So about the methemoglobin, what should I know? About the methemoglobin, I should know that, so this is the methemoglobin, right? Methemoglobin. Okay, And what should I remember for the methemoglobin? About the methemoglobin, I should remember that it can actually happening with the help of nitrate poisoning, right? Nitrate poisoning. Okay, methemoglobin, and due to that your body will change into bluish color. So bluish tint will be seen in your body, so bluish discoloration, because your body is not getting proper amount of oxygen, obviously. Okay, because instead of oxyhemoglobin, your body is having which one? That is the methemoglobin. Okay, so let me move further from here. Now let's talk about the question number 86. In the question number 86, as you can clearly see that there is a mentioning of about they are actually mentioning about what? Sickle cell anemia, right? They are mentioning about sickle cell anemia. About sickle cell anemia, you are already known that there is a substitution of glutamic acid by the valine, right? Substitution of glutamic acid by valine. So I can write over here. So what can be the answer over here? That is the substitution of glutamic acid by valine. At which position I can add? At which position I can add over here? So that will be at sixth position, right? At sixth position, substitution of valine with the glutamic acid, right? Okay, so let's move further. Question number 87. So in the question number 87, they are talking about the alpha thalassemia over here. In the alpha thalassemia, right? So if you talk about alpha thalassemia, yeah, if you talk about thalassemia, first of all, thalassemia comes in the category of microcytic anemia, first of all, and we are having two types of we are having two types of thalassemia. One is thalassemia alpha, which is a problem in the alpha globin chain of hemoglobin, so that is the alpha thalassemia, and one is the beta thalassemia, right? In the beta thalassemia, we are having the problem in the beta globin chain of the hemoglobin, right? So if they are talking about thalassemia, we have already talked about that we are having the appearance of the target cell, right? Or target like appearance of the RBCs. So that is the main key finding of the thalassemia as far as histological appearance is concerned, right? So what can be the answer over here? That is the target like RBCs or target like erythrocytes, right? Let's move further. If you talk about question number 88, they are saying that this patient is having the respiratory viral infection treated with sulfonamide drugs, right? Treated with which drugs? That is the sulfur drugs. And what are the sulfur drugs? Yeah, from the pharmacology, yes, absolutely, we know that we are having the combination, for example, biceptol, that which is a combination of sulfamethoxazole and trimethoprim, right? So in this one they are talking about the sulfonamide drugs, and blood test findings revealed hyporegenerative normochromic anemia. So look over here, they are talking about what they are talking about. They are talking about the normochromic anemia over here, first of all. Okay, anemia, then leukopenia. Anemia, you know that this is the lack of RBC. Leukopenia, you know this is the lack of WBC or leukocyte. And the next term over here which they are using, they are talking about thrombocytopenia. Thrombocytopenia is deficiency of RBC, so thrombocyte, right? So, and next which you can see that there is a decreased amount of myelokaryocyte was found over here. So what can I say over here? That I am having the problem of deficiency of RBCs. This patient is also having the deficiency of WBCs, and this patient is also having the deficiency of platelets. So I can clearly say that these three things, if they are saying that, I can clearly say that this is the finding of which anemia? Yes, that is the finding of aplastic anemia, right? Aplastic anemia, or you can say hypoplastic anemia, okay, in which the bone marrow is severely decompressed, right? So what can be the answer over here? Clearly we can say that answer is aplastic anemia or hypoplastic anemia, right? Okay, moving further, now let's talk about the question number 89. Okay, in the question number 89 you will see that microcythemia, polycytosis, annulocytosis were found in the patient blood smear. What anemia are characteristic for this one? So what can I see over here? Clearly I can see that they are talking about the microcythemia. Okay, Microcythemia, which means I can say that clearly that they are talking about the microcytosis. What they are talking about is they are talking about the microcytosis, which means the MCV, which is mean corpuscular volume, is less than 80. Okay, and they are talking about the which kind of anemia. Yes, I can say this here. This is the example of hypochromic anemia, and I can clearly say over here, which means that color index is less than 0.85, and they are talking about what? They are talking about which kind of anemia. Yes, you already know, that is the iron deficiency anemia. Okay, what is that? That is the iron deficiency anemia, right? Moving on to the next one, question number 90. They are talking about the B12 deficiency. Okay, so let me read the full question. After the resection of the stomach, right? So in the previous history, there is a resection of the stomach. So what can I see over here is that they're talking about the resection of the stomach, and they are saying the patient developed B12 deficiency, right? Anemia and B12 deficiency anemia. What color index? Okay, so what is the normal value of color index? I would like to ask first of all. So yes, that is, so color index normal range is 0.85 to 1.15. We have already discussed about that multiple times, and less than 0.85 is hyperchromic, more than 1.15 is hyperchromic. If they're talking about B12 deficiency anemia, yes, obviously the color index will be more than 1.15. And we are going to talk about which kind of anemia. Absolutely, we are going to talk about the macrocytic anemia, or I can say over here is that is the megaloblastic anemia. So you just need to recognize among the given option that which one is more than 1.15. Yes, you are right, that is 1.4, right? So that is the answer over here. So it's quite easy. Moving on to the next one. Question number 91, right? Question number 91, you can see over here hemoglobin is less, obviously, for any kind of patient, whether it is male or female. Hemoglobin, they are actually giving you the value which is quite less over here, which is given hemoglobin 80 gram per liter. Okay, that's fine. Erythrocytes are also little less. Look at the leukocyte level. Leukocytes levels are pretty high, right? 4 to 9 is the normal value. 4 to 9 into 10 raised to power 9 per liter is the normal value for the leukocytes. Looking over here, I can see that look at the neutrophils count. Okay, because they are important for this one. Look at the metamyelocytes, which are actually given 22%, quite high over here. Look at the stab neutrophil count. Stab neutrophil count is 17%, which is obviously high in this patient. And what can I say from these findings? That this patient is having the myeloleucosis. Okay, so myeloleucosis, or you can say myelosis. Okay, so I can clearly say over here that this is a case of myeloleucosis or myelosis. Okay, so what can I write over here with that? It can be also called as myeloleucosis. Okay, myeloleucosis, fine. Now look at the question number 92 right here. So in the question number 92, what they are saying, a woman complains of headache, giddiness, dyspnea during physical activity for the last 3 years. She has been, so look, let me add one more image over here. Yeah, so look at this one. So yeah, that is making the continuity over here now. So question number 92, a woman complains of headache, giddiness, dyspnea during physical activity for the last 3 years. She has been having extensive menstrual bleeding. Yes, so that is the main point over here for us. So that is the main key finding over here, extensive menstrual bleeding. Okay, and they are telling you about the hemoglobin level, which is obviously less. Just now we talked about the hemoglobin levels normal values, which is actually 120 for the female, 120 gram per liter, and 135 gram per liter for the males. Erythrocytes levels are 3.7, little less. Color index is 0.7, right? So look at the color index value, which is 0.7. Obviously it is less than 0.85. This can be the case of iron deficiency anemia. But however, they have already mentioned about the extensive menstrual bleeding, which gives you the preference of which answer, that is the post hemorrhagic anemia. Okay, now you will ask why it is chronic, because they are already giving you the history of these kind of hemorrhage, which are the extensive menstrual hemorrhage, extensive menstrual bleeding, they are actually happening for over 3 years. Okay, so that is actually giving you the hint of what. So further they are actually also saying that hypochromia, obviously we can see the given color index is quite low, so we can actually estimate our answer very easily, that is the chronic post hemorrhagic anemia, right? Okay guys, so let's move further. So question number 93. So in the question number 93, what they are saying is that yes, again the question is quite easy. They are talking about what? They are talking about the color index. Color index is given over here, which is 1.4, and it is megalocytic anemia, megaloblastic anemia, and you can see prevalence of what? Megaloblast are present over here. Question is quite clear, so we can actually answer our question very confidently, that is the B12 and folic acid deficiency, right? Okay, moving further, question number 94. So again they are talking about what? They are talking about the Mcqs disease. We have already talked about that thing in the previous questions, that in the case of Mcqs disease, we are having the membranopathy, and spherocytosis may happen further, that can be hereditary. Further, I told you ANCA and spectrin proteins are deformed over the RBC membrane. So that is the main problem here. So what can be the case? Yes, that is membranopathy, right? What is that? That is membranopathy. Right? Okay. Moving further, question number 95. In the question number 95, they are saying that they are actually revealing what? Leukocytosis. That's fine, they are telling you about the leukocytosis, but what they are already saying, that what is the main finding over here, that is the Botkin-Gombrich cells. Okay, that is the Botkin-Gombrich cells. So look at the image of this question properly. So yes, what they were saying, Botkin-Gombrich cells, right? Yes, Botkin-Gombrich cells, right? And anemia. Okay, so what can be the answer? We know Botkin-Gombrich cells are seen in chronic lympholeucosis, also called as chronic lymphoid leukosis. So that will be the answer in this case, right? So that is the chronic lymphoid leukosis, or it can come as chronic lympholeucosis as well. Okay, it can come as chronic lympholeucosis as well. Okay, chronic lympholeucosis. Okay, moving further, let's see question number 96. Look, autoimmune process means like antibodies are actually forming inside your blood circulation, and they are actually acting against the thrombocytes, and they are that is the situation which is prevailing over here. They were saying thrombocytopenia, autoimmune process. So look, antibodies will be forming inside blood circulation, and they will try to kill definitely they will try to kill the thrombocytes over here, and which will lead to what? Thrombocyte destruction. So it's a simple case of what? So there will be the increased destruction of thrombocytes. Okay, increased destruction of thrombocytes, right? Moving further, question number 97. Question number 97, they are saying that yes, this is a problem of sickleemia. Sickleemia means sickle cell anemia. Sickle cell anemia is substitution of glutamic acid with valine at the position of 6th. There's that 6th position, and what is happening in that one? Normal RBC is actually changing its shape from biconcave to sickle cell, which looks something like this, right? So that is a sickle cell, and in this one we are having which kind of hemoglobin? That is the HbS form, right? HbS is not compatible with life, so that is incompatible with life, right? So that is the problem. So where is the hemolysis happening? That is inside the cell. So intracellular hemolysis is going on, right? So which hemolysis? That is the intracellular hemolysis is going on, right? Moving further, question number 98. In the question number 98, they are saying that a clinical observation of 50-year-old decreased amount of erythrocytes, first of all. So decreased amount of erythrocytes, which means anemia they want to say in the blood, and increased level of free free hemoglobin, right? So they are giving you one more hint that erythrocytes are getting destroyed. That means, and due to that, if the if the RBC will be destroyed, then hemoglobin, they are carrying the hemoglobin will come out from the from the RBCs, and now hemoglobin is actually a toxic. Hemoglobin is toxic to your blood circulation. They should be actually binding to some kind of molecule which can be acting as transporter, and in that case that is transferrin, right? And now what is happening, free hemoglobin is there, and that can cause a toxicity in your blood plasma. Further, current index 0.85, which is almost normal. So what kind of anemia? So I will say that this is a case of hemolytic anemia, because the hemolysis is going on at a higher rate over here. So I can say over here they are actually talking about the hemolytic anemia. And look at the age of this patient, that is a 50-year-old, right? So this is not hereditary, actually, rather I should say that this is the problem of acquired. So I can say this is the acquired hemolytic anemia, right? Okay, so what is that? That is the acquired hemolytic anemia. Fine. So that is the case over here. So let's see further image. Okay, let's see further image. So let me add one more image over here, and it will make more sense then. So yeah, this one. So look at this one. So 98. So what can be the answer? Okay, that will be acquired hemolytic anemia. Look at the next question, chronic diffuse glomerulonephritis they are saying. So in the chronic diffuse glomerulonephritis, which means definitely there is an injury of the kidneys, right? They are suffering from anemia. What they're suffering from anemia. So in the nephron region, we are having the PCT, right? In the nephron we are having after the glomerulus we are having the PCT, proximal coronary tubule, and proximal coronary tubule is responsible for the reabsorption of sodium ions, and various kind of amino acids. For example, let it be glucose, let it be some kind of some other amino acids, it can be proteins and all these things, right? So the PCT is doing a lot of things. And an additional function which you can say is that they are actually releasing a very important hormone, and that is also called as erythropoietin. Okay, and erythropoietin, as the name suggests, erythropoietin means they will be stimulating the erythropoiesis. So they goes to the bone marrow, and they are actually responsible for stimulating the process of erythropoiesis, right? So erythropoietin is releasing from the PCT region, and if the patient is having the glomerulonephritis, the PCT will be damaged. So if the PCT will be damaged, they will not be able to produce the erythropoietin, right? Which hormone? Erythropoietin. So that is the problem. So if the chronic diffuse glomerulonephritis is there, definitely they will not be able to produce what? Erythropoietin. So decreased production of erythropoietin will be seen in our patient, right? So let's move further. Okay, let's move further and let's talk about question number 100. So they are saying the peripheral blood of anemia, what they are saying, toxic hemolytic anemia, right? What they are saying, toxic hemolytic anemia. So in the toxic hemolytic anemia, you can say hemolytic anemia, I just told you a previous question number 98, they were talking about the acquired hemolytic. In the toxic hemolytic anemia, degenerative and regenerative, both kind of forms of erythrocytes are seen. What cells refer to be regenerative, right? So look, if you talk about toxic hemolytic anemia, so demand from our body will be increasing for the RBCs, and in that case immature RBCs can be appearing in the blood circulation. And uh, you must be aware of that from the hematology, that what are the precursor of RBCs? That is the reticulocytes. Okay, so reticulocytes are the precursors for RBCs, and if the demand will be increasing from our blood side, because there is already hemolysis of RBCs going on, toxic hemolytic anemia is going on. So in that case, even immature RBCs can be appearing in the blood circulation. And immature RBCs, that is actually reticulocytes, they do contain the nucleus as well. Okay, so what can be the answer over here? Yes, that can be reticulocytes. Okay, that can be reticulocytes. Look at the question number 101 now. Question number 101, they are talking about 45% of HbS, 45% of HbS means what? 45% of HbS means these persons are carrying the hemoglobin S, and which is the incompatibility with life, right? And just now I told you HbS is present in sickle cell anemia. Okay, and look at the percentage of HbA1, that is 55%. Okay, so HbS means what? As for sickle cell, right? So they are actually talking about which kind of problem they are actually talking about. Which kind of problem they are talking about? Sickle cell anemia, which they are writing over here as sicklemia, right? Let me tell you about one more thing. One more important info over here is that HbA is present in adults. HbA present in adults. For example, one is given over here, that is HbA1, right? So it can be HbA1, HbA2. A is for adults. HbF is present in fetus. Okay, so as we approach our age, okay, as we are growing older, our HbF is actually moving into HbA, right? HbF is present in fetus. And next, HbS, as this question is also mentioning, as for sickle cell anemia, right? Sickle cell anemia. Okay, so no problem at all in this one. Okay, so now let's move further. Let's look at the question number 102. Question number 102, they are saying actually that this 40-year-old woman who regularly used what? Who regularly used aspirin. Now aspirin, from the pharmacology we know that aspirin is also called acetylsalicylic acid, and this comes in the category of NSAIDs, which is the non-steroidal anti-inflammatory drugs. They actually developed hemorrhages. Obviously hemorrhages, we know that GIT bleeding may happen actually, or because it is actually inhibiting the COX-1 as well, right? As you know that it is having the anti-inflammatory reaction, so COX-1 is present in the GIT mucosa and can lead to hemorrhages very easily, right, as a side effect. So disturbance of functional activity of thrombocytes was revealed. So thrombocytes are not working well over here. So disturbance of thrombocytes. And depression of which enzyme they are asking you. Depression of which enzyme, as I told you just now, that they are actually COX inhibitors. They are actually NSAID. So aspirin is what? Aspirin is actually your NSAID. Okay, so aspirin, I can say over here is that this is the category of NSAID. And non-steroidal anti-inflammatory drugs, they are also we are also calling them as in the category of non-opioids. And depression of which enzyme? Yes, obviously this is the COX inhibitor, right? So what can be the answer? COX is full name of COX is full form of the COX is, yes, that is cyclooxygenase, right? So aspirin is actually COX-1 COX-2 both kind of inhibitor, so I can say that this is a COX inhibitor, right? So there is a cyclooxygenase. Okay, no problem at all in this one. Let's look at the question number 103. The 103, they are talking about the fatigability. This 58-year-old woman, she is quite old, and fatigability, sleepiness, dyspnea while when walking fast. Okay, so erythrocyte level is 4, and this one color index is 0.6. So our color index, so with the help of color index only, we can know that we have now clear discussion about the color index, and we know the normal value as well for the color index, and what is the 0.85 to 1.15, which is clearly less over here. Okay, and plenty of annulocytes and microcytes. And microcytes, I told you what was microcyte. Microcyte means MCV is less than 80, right? So that is a smaller size. And color index is 0.6, which means that is hypochromic, right? Color index if it is less than 0.85, which is 0.6, which is given over here, so in that case I can clearly say that they are talking about the hypochromic anemia. And hypochromic and microcytic anemia, I told you the example. Which example I told you? Yes, that is the iron deficiency anemia. Please remember some of the symptoms of iron deficiency. For example, brittling of the nails, okay, falling of hairs, problem in the gums. Okay, so that is the problem of what? Iron deficiency, right? So yeah, spoon like nails can be there. Okay. Yeah, so that can be the thing over here. So what can be the answer? Yes, clearly I can say that the answer over here would be iron deficiency anemia, right? Question number 104, let's talk about that as well. So question number 104, iron deficiency anemia is diagnosed atrophic and dystrophic changes in the. So what they are saying, clearly they are mentioning about the iron deficiency anemia, first thing. Then the atrophic and dystrophic process in the alimentary canal. So look, glossitis, gingivitis, caries, esophagitis, they're actually the signs of iron deficiency. And what causes a change in the patient organism? Yeah, obviously if the patient, if they are talking about iron deficiency anemia, Yes, which means they are talking about what they are talking about, the enzymes level. So enzymes level of iron, yeah, so iron deficiency will be seen. So iron enzymes will be deficient over here. Okay.